Very good morning to one and all. I am Dr. Sanmugapiriya. Today's topic for discussion is weaning from mechanical ventilator. So before going to the topic per se, have you all know what is a mechanical ventilator? Yeah, last class I have taken. So similarly, we are going to continue in this class for weaning from the mechanical ventilator. So the content what we are going to learn in this topic is, from this session, we are going to learn the definition of weaning and weaning success and weaning failure and patient condition prior to weaning. And the next is weaning criteria and ventilator weaning criteria, rapid shallow breathing index, weaning procedure, and what are all the protocols and the terminal weaning. So these are all the things we are going to see in this lecture. So what is the definition for weaning? It is the process of withdrawing the mechanical ventilatory support and transferring the work of breathing from the ventilator to the patient. So the patient takes automatically his own breath. Initially, the last class we have seen is the ventilator giving the breath to the patient, and in weaning, the patient has to take his own breath. So weaning success and weaning failure. So the main criteria is the ability of the patient to breathe spontaneously. And weaning success is defined as a ventilatory support 48 hours following the extubation. Weaning in processes, that is progresses, immediate, it is an immediate category, intermediate category. And weaning failure is nothing but, it is defined as either the failure of the spontaneous breathing trial or the need of re-intubation within 48 hours following an extubation. So we are again re-intubating the patient. So if you are re-intubating the patient within 48 hours, is nothing but whatever we have weaned or extubated, it is a failure to them. So weaning in processes, it is an intermediate category. So we are making the patient weaning from the ventilator, doing the process. So it is an intermediate category, whereas weaning success is the patient is successfully taken out from the ventilator, that is off the ventilator support from 48 hours following an extubation. Then the patient condition prior to the weaning. So how we can categorize the patient, whether we can wean this patient from the ventilator or not. So that is the patient condition prior to the weaning should be, before weaning, the patient should have recovered from the acute phase of the disease, that is leading to the mechanical ventilation, and to be able to assume an adequate spontaneous breathing. So these are all the conditions prior to the weaning. Patient conditions, for example, patient or the pathophysiological condition. If the patient is having high-grade fever or infection or renal failure, patient is having sepsis or sleep deprivation. So this patient, these are all the patient, they are likely, they should not wean from the ventilator. If you are weaning this case, it will become a failure of weaning. So once they are come out of this pathological condition, we can make sure the patient can be weaned off. And the next is the cardiac and the circulatory status. There should not be any arrhythmia, and the blood pressure should be normal. It should not be too high or too low. Cardiac output should be maintained normal, and the fluid imbalance, that is an electrolyte imbalance or fluid balance, should be normal. And we have to correct the anemia, because anemia, if the patient is having a hemoglobin of 5, the oxygen carrying capacity is low. So the patient will not have the ability to breathe spontaneously, because the oxygen carrying capacity is already low in the hemoglobin if the HB is very less. So anemia patient, we have to correct it. And the dysfunctional hemoglobin. And the next is the dietary or the acid base and the electrolyte imbalance. For example, if the caloric is deficient or very severe malnutrition patient, where they will have increase in work of breathing. So if they have increase in work of breathing, we can't wean that condition. So the patient has to be cleared off. So His calorie should be normal, and their acid base imbalance should be corrected, and electrolyte imbalance should be corrected. So these are all the hindering factors. So you have to treat this hindering factor, then only we should go for the patient for weaning. Then moving on to the weaning criteria. This is the most important thing. You all should know this. So there are so many criteria. There are clinical criteria, ventilatory criteria, oxygenation criteria, pulmonary reserve, and the pulmonary measurement. For example, the clinical criteria. Resolution of acute phase of the disease. It should be that I have told no the previous slide. Acute phase of the disease like fever and so many things has to be corrected. And patient should have an adequate cough, because if any foreign material got obstructed or something is lodged into the air column, patient has to have an adequate cough to expel it out. Then absence of excessive secretion. If patient is having excessive secretion, we can't wean them. That itself will cause silent aspiration and cardiovascular and hemodynamic stability. So the clinical criteria should fit into this thing, then only they can go for a successful weaning. Then moving on to the ventilatory criteria. There are so many ventilatory criteria. The first one is spontaneous breathing trial. They should tolerate at least for 20 to 30 minutes. We should make the patient for spontaneous breathing trial. At least they should tolerate for 20 to 30 minutes. Should be more important. Then next is PaCO2. In ABG, we should look for it. If the PaCO2 of less than 50 millimeter of mercury, then we can ask the patient for, we can do the trial. And the vital capacity, it should be more than 10 ml per kg. And the spontaneous VT should be more than 5 ml per kg. Then spontaneous, that is that minute ventilation should be less than 10 liters with the satisfactory ABG. ABG should have, you will be knowing that carbon dioxide, and there should not be any respiratory acidosis or alkalosis or metabolic acidosis or alkalosis. So ABG should also fit into normal, and their minute ventilation should be less than 10 liters. Okay. Then moving on to the oxygenation criteria. PaO2 bar FiO2 ratio is also more important in oxygenation criteria. See, first is partial pressure of oxygen saturation without the PEEP. It should be more than 60 millimeter of mercury at an FiO2 of 0.4. That is 40% of oxygen. And the next is PaO2, that is partial pressure of oxygen with the PEEP, that is less than 8 centimeter of water. It should be 100 millimeter of mercury, where the FiO2 should be less than 40%. And SiO2 should be more than 90%. Here you can see the FiO2 should be less than 40%. We should not make the FiO2 of 100%. Okay, if that means we are giving 100% oxygen to the patient, and then it is difficult to take out the patient from the ventilator. So we should first reduce the FiO2 to 40%. Then only we should go for the trial of weaning. Then moving on to the PaO2 bar FiO2. PF ratio should be less than or equal to 150 millimeter of mercury. QS by QT should be of less than 20%. And partial pressure of arterial minus alveolar oxygen should be less than 350 millimeter of mercury with an FiO2 of 100%. Okay. Then the pulmonary reserve. Vital capacity should be more than 10 ml per kg, and the maximum inspiratory pressure of more than minus 30 centimeter of water in 20 seconds. And the next is the pulmonary measurement. There are two complaints, static complaints and dynamic complaints. In that static complaint should be more than 30 ml per centimeter of water, and airway resistance, it should be stable or it should be improved. And VD by VT should be less than 60% while extubation. Then moving on to the general ventilatory weaning criteria, where the PaCO2 should be less than 50 millimeter of mercury, as I told you, with the normal pH. And the vital capacity should be more than 10 ml per kg. Spontaneous tidal volume should be more than 5 ml per kg, and the spontaneous frequency should be, that is the rate should be less than 35 per minute, and F by Vt should be less than 100 breaths per minute. That is the spontaneous frequency. Then the minute ventilation should be less than 10 liters with a satisfactory ABG. See, as I told, no, the normal PaCO2, that is PaCO2, it should be 35 to 40 millimeter of mercury. Under pH, between 7.35 to 7.45. For the COPD patient, the PaCO2 may be 50 millimeter of mercury can be considered, and the pH can be of 7.35. Then moving on to the vital capacity and the spontaneous tidal volume. The vital capacity and the spontaneous tidal volume that usually correlates with the success weaning of more than 10 ml per kg, and it is 5 ml per kg respectively. Okay, this 10 ml should be the vital capacity, and the spontaneous tidal volume should be 5 ml per kg. The vital capacity maneuver is an effort dependent. The proper teaching and the coaching is required for the accurate and the valid measurement. Then moving on to the spontaneous frequency, that is rapid shallow breathing. Index is also plays an important role. The dead space ventilation, and this is highly ineffective for an gaseous exchange during a spontaneous breathing. And F by Vt index of 100 breaths per minute, that is breaths per minute per liter, usually correlates with the weaning success. And moving on to the minute ventilation. For a successful weaning outcome should be obtained, the patient minute ventilation should be less than 10 liters per minute with an accepted ABG. Moving on to the oxygenation criteria. For a successful weaning to become, the PaO2 should be more than 90%, and it should not be less than 60 millimeter of mercury. Okay. And PaO2 bar FiO2 ratio, that is PF index. It is a simplified method. This is also more important. Instead of seeing for the oxygenation or carbon dioxide criteria, which we will be looking after in the ABG, we can see this using this ABG, PaO2 bar FiO2 ratio. It should be 150 millimeter of mercury. It's an acceptable physiological shunt. So once we see that it is a 150 millimeter, we can make the patient ready for weaning. We can expect those patients we can have a successful weaning. Then QS by QT, that is the physiological shunt to a total perfusion. The ratio is used here is extreme, how much the pulmonary perfusion is wasted. See, this is the equation, as you all know, that is QS by QT ratio can be calculated using the classical physiological shunt formula. That is QS by QT equal to N capillary oxygen content in and the volume percentage, and the arterial minus arterial oxygen content in the volume percentage divided by N capillary oxygen content in the volume percentage minus mixed volume oxygen content in volume percentage. So this is the classical physiological shunt. So this should be, the physiological shunting should be, normal should have less than 10%. If mild shunting is present, it should be 10 to 20%, and it's significant, it is 20 to 30%. Greater than 30% is severe. For a successful weaning to be an outcome, the QS by QT should be less than 20%. And moving on to the rapid shallow breathing index. So this is a more important thing for an extubation criteria, that is weaning criteria. It is rapid shallow breathing. It induces an inefficient dead space ventilation. That is F by Vt index, number of spontaneous breaths per minute divided by the tidal volume. Spontaneous, how much he is taking, divided by the tidal volume in liters. Absence of rapid shallow breathing as defined by where the spontaneous breathing divided by the tidal volume ratio of less than 100 breaths per minute per liter. It is an accurate predictor for a weaning success. We should make this trial. If the breathing is less than 100 breaths per minute, so we can adequately wean the patient. So these are all the procedures how we are going to check the spontaneous SBT trial. Allow the patient at least 3 minutes to stabilize the spontaneous breathing pattern. That is, the ventilator frequency must be off and the PSV should not be used if the patient is not tolerable. And then you should measure the expired volume and the respiratory frequency for 1 minute. Then divide the minute ventilation by the frequency so as to obtain an average tidal volume in liters. Dividing F by Vt, we can obtain the spontaneous breathing trial. So here the patient is ready for weaning from the mechanical ventilation and then the patient is for extubation. This is the spontaneous breathing trial. The spontaneous breathing may be augmented with a low level that is less than 8 centimeter of water of pressure support from in CPAP or an automatic tube pump. Now moving on to the weaning procedures. The first comes is spontaneous breathing trial. This is nothing but an evaluation of patients' readiness for weaning from the mechanical ventilation and extubation. Spontaneous breathing may be augmented with low levels of pressure support, that is less than 8 centimeter of water, CPAP or automatic tube compensation, that is ACT. Then SBT may be, usually we have to last up to 30 minutes. Moving on to the stepwise procedures, how we are going to do the spontaneous breathing trial. So first step in SBT is may use the T tubes or CPAP or automatic tube compensation. Let the patient breathe spontaneously for 30 minutes. And then you can use the low level pressure support. That is 8 centimeter for adult and 10 centimeter of water for pediatrics to augment the spontaneous breathing. Then you have to assess the patient. If the patient tolerates the step 4, that is you can wait for 30 minutes, then you can consider the patient for extubation. Not only this parameter, we have to check the ABG and vital signs are also should satisfactory. Then return the patient to the mechanical ventilation. Return patient to the mechanical ventilation to the rest if necessary. Then if the patient is on SIMV, this is not recommended as in standard alone mode for weaning. So once if you want to extubate, don't extubate at the time of SIMV. You have to move on to the next step. So first reduce the SIMV, that is ventilatory frequency, by 1 to 3 breaths per minute. Then monitor the saturation, that is SpO2. Then obtain an ABG as usually we will be doing daily. Then you have to assess the ABG. Then reduce the SIMV frequency further until an frequency for 2 to 4 per minute is reached. Then usually then this may take 1 hour for a patient with a normal cardiac function. But if the patient with an abnormal cardiac function, it will take days together from reducing the rate in the SIMV. If the patient tolerates the step 3, then consider for extubation along with the ABG and vital signs if they are satisfactory. If the patient is on pressure support, that is PSV, then you have to do this following steps for spontaneous breathing trial. PSV may be used in conjunction with the spontaneous breathing or SIMV mode. Start the PSV at a level of 5 to 15 centimeter of water. That is up to 40 centimeters is the maximum. Then to augment a spontaneous tidal volume, that is until it is desired as 10 to 15 ml per kg, or a spontaneous breathing frequency of less than 25 per minute. That is normal respiration should be less than 25 per minute is reached. Then decrease the pressure support up to 3 to 6 centimeters of water. Then if the patient tolerates the step 3, then consider for extubation. As usual, I told along with the ABG and vitals to be satisfactory. Here, this is the clinical criteria. These are all the following clinical criteria where the SBT is failed. When we can say the SBT is failure has occurred. If the PaO2, that is less than 60 millimeter of mercury on FiO2 of more than 50%, that is then SaO2 of less than 90% on FiO2 of more than 50%. Then partial pressure of carbon dioxide, that is more than 50 millimeter of mercury, or increase in PaCO2 of 8 millimeter of mercury from the baseline of SBT. That is, after SBT trial, we should check the baseline ABG. No, that ABG, if there is an increase in PaCO2 level of more than 8 millimeter of mercury, then we can consider as a failure of SBT. Then the pH, that is less than 7.3, or decrease in pH more than 0.07 from the baseline of the SBT. Then the spontaneous breaths of more than breathing trial, that is of more than 100 breaths per minute per liter, or round of approximately 105 minutes, then we should consider as a failure. If the breathing of more than 35 breaths per minute or increase up to 50% from the baseline of the spontaneous breathing, or if the heart rate is more than 140 per minute or more than 20% from the baseline of the SBT, or if the systolic blood pressure more than 180 per minute or systolic blood pressure of less than 90 millimeter of mercury. Everything, if it is more than 20% from the baseline of from the SBT means we should consider as failure in SBT. Then any presence of cardiac arrhythmia. Once you are planning for weaning, at that time, if the patient has been noticed to have one cardiac arrhythmia, then you should not you should not continue the SBT. So these are all the failures in failure of SBT criteria, clinical criteria. Then moving on to the weaning protocol from a mechanical ventilator. So first step is, does the patient shows any evidence of some reversal of underlying causes for ventilatory failure, or presence of any inspiratory effect is there or not? If the hemodynamic stability is present or not, that is absence of myocardial ischemia or hypotension or use of any vasopressor. If the patient is then come out of this, then we can consider for the criteria. Then adequate oxygenation and the ABG status, that is PaO2 bar FiO2 of more than 150 millimeter of mercury, and the pH should be less than 8 centimeter of water, and the pH of should be of more than 7.25, and the light sedation or better. Before eye contact or voice command should be followed. If everything is what and all the patient criteria comes to be yes, then you should proceed for weaning. If there is no in any one of the question, postpone your weaning until for the next day. So morning once if you go for the rounds, you should look for this thing. If the patient is satisfactory, then go for the next step. Then perform and measure the rapid shallow breathing index, which is it is mandatory the frequency turn off and pressure support, that is 8 centimeter of water and the PEEP of less than 5 centimeter of water. Then measurement should be taken up, that is following every 3 minutes of spontaneous breathing. That is spontaneous breathing, then every third minute you have to assess. If the rapid shallow breathing index of less than 100 breaths per minute per liter, then you should proceed for the next step. If it is more than 100 breaths per minute, the rapid shallow breathing index of more than 100 or roughly 105, then your weaning is failure. Even though first step they have come to the next step, then here also if the patient is not satisfactory, then we can postpone to the next day. Then if all the patient is satisfactory, then go to the next step. Patient can tolerate both things. Then spontaneous breathing trial should be continued for 30 minutes without any termination. So if it is yes, then proceed the ventilator discontinue. If the patient can tolerate for 30 minutes, then discontinue the ventilation and plan for the extubation. If the patient in between, that is after 15 minutes or immediately after 10 minutes, if the patient is not able to continue the SBT, then stop the weaning process, then consider for the next day weaning trial. See, these are the weaning failure, early signs. So the patient is not tolerating, the patient will have tachypnea, use of accessory muscle, paradoxical abdominal movement, dyspnea, chest pain, chest and abdominal asynchrony, and diaphoresis. If you find this features in the patient, then you can very well say the patient is failed from the weaning. Then you should plan weaning on the next day. Patient may hyperventilate due to hypoxia, anxiety, pain, or inappropriate ventilator setting. It is a grave mistake to reduce the ventilator support simply because the PaCO2 shows hyperventilation. So indications for the weaning failure, as I told you the previous thing, if the ABG shows any abnormality, increase in PaO2 or decrease in pH, PaO2, decrease in SpO2 or decrease in PaO2 bar FiO2 ratio, and vital sign where the change in blood pressure, that is systole or diastole, that is less than 20 millimeter or more than 20 millimeter of mercury from the baseline, or increase in heart rate, that is 20 per minute or more than 110 per minute, or an abnormal ECG, presence of any arrhythmia, considered for weaning failure. In the respiratory parameters, if there is a decrease in tidal volume, that is less than 250 ml, or increase in frequency, or increase in F bar VT, that is spontaneous breathing trial of more than 105 breaths per minute, or decrease in MIP, that is less than minus 20 centimeter of water, decrease in static compliance, that is less than 30 ml per centimeter of water, or increase in VD by VT, that is more than 60%. These are all the indicators for the weaning failure. Then moving on to the causes for weaning failure. So the first cause is increase in airflow resistance. When the ET tube size of 8 or larger should be used to reduce the airflow resistance. And decrease of complaints, that is low lung or the thoracic complaints make the lung expansion difficult, and it is the major contributing factor for the respiratory muscle fatigue and the weaning failure. Then moving on to the respiratory muscle fatigue, that is work of breathing is equal to PTV by VT. So what are all the complaints under condition related to the to our weaning strategy? If there is decreased static complaints, where you can see where in athletics, ARDS, tension pneumothorax, obesity, and retained secretion in the lungs. These are all the conditions where you can see the decreased static compliance. And decreased dynamic compliance, you can note it at the time of bronchospasm when there is thinking of tube, endotracheal tube, airway obstruction, and retained secretion in the airway. These are all the conditions where we can have the decreased compliance. And final termination from the weaning. Terminal weaning is nothing but withdrawing the mechanical ventilation can result in the death of the patient. Terminal weaning may be justified if the medical intervention is futile, or also to stop the pain and suffering. So this is the one more new entity, that is the terminal weaning. Discussion of the patient, discussions on a patient's informed consent should be done over a period of time so that emotion, pain, and other intangible factors that do not interfere with any informed and valid decision. So these are all the references. Thank you.